I want to start off with full disclosure. I love steroids. Not necessarily for myself. I love giving them to my patients. I think they work great. I think they're fantastic. And what got me interested is that, we were pummeling patients with prednisone, and I was thinking about, well, I'm not talking to them about what the risks are. I don't really even know what the risks are. And so I started looking into this a little bit more. And then it's funny because I would talk to the rheumatologists, and they would say, yeah, so? And I'd talk to the pulmonologists, and they'd say, okay, yeah, whatever. And I couldn't understand why they weren't more interested in this, and why don't you care a little bit more? And then I had this kind of this epiphany. It's a risk-benefit question. So if they're giving patients prednisone for a bad asthma attack, and that patient may die if they don't give them prednisone, that's a lot different risk-benefit strategy or a cost-benefit analysis than us who are giving patients prednisone for a stuffy nose. Right? So that's the difference. And so I think it's important that we are aware of these risks and how big of a risk they are and ways to try to mitigate that risk. And so that's what I want to try to do in the next 20 minutes or so. So oral steroids, we all use them. We all know them. I tell all my patients they're a great drug short-term. They're a terrible drug long-term. The problem is that no one really knows the safety profile for recurring courses like we like to give. Oral prednisone, that's the workhorse. It's metabolized by the liver. It is metabolized into prednisolone. The bioavailability is about 92%, and the half-life is about 3 hours. A lot of potential side effects, and I used to give this talk at the academy when I had an hour, and I would go through each one of those and the data on that. And if anybody has interest, afterwards we can talk about some of the specific side effects. But what I want to do more is talk about what we're using and then the risk association or the risks associated with that from a medical legal standpoint. So there's been a few different papers looking at the steroid use in sinus management in the United States and other places. The first was by Mickey Stewart in 2006, and he surveyed the Academy membership, got 80 respondents, and about a third of them said that oral steroids were considered part of their maximum medical therapy. So about a third of them, if they were pummeling or they were treating these patients medically, steroids were definitely a part of that. Mark Dubin, who many of you know, he did a similar survey of the American Rhinologic Society, and of the 308 respondents, 51.5% of those patients were using steroid more than half of the time. So the point is that the majority of patients, the majority of providers use steroids the majority of the time. Right? About 10% always used steroids. Their course duration ranged from 6 to 14 days, and this is what struck me as the most interesting. The mean starting dose was 50 milligrams per day with a huge range. Some people were giving them 10 milligrams as a starting dose, other people's 120 milligrams as a starting dose. So huge range. And then there was a study out of the United Kingdom that looked at providers. 61% of those respondents were rhinologists. And interestingly enough, 66% of those respondents said they rarely or never used oral steroids for chronic rhinosinusitis. So it's really interesting, a stark contrast from the US. So what kind of liabilities do we have by prescribing this? What is our risk? So this is something that I was interested in, and so we did a review of this, and we looked at the medical literature to try to get a better idea of what has been published regarding lawsuits for corticosteroids. And so we did an Ovid search, and you can see the search parameter if you're interested. And what we found was that there's 178 articles, and we were able to whittle them down to 4 articles that actually had details regarding lawsuits as far as who was being sued, how much they were being awarded, those sorts of things. So the first one was published in 1993, and it was from the Physician Insurers Association of America, PIAA. and they reviewed 117,000 claims. And what they found was the medication errors were the second most common, and they were also the second most expensive claims to the plaintiffs. And they had an average indemnity payment of over $120,000. A second study in '95 from the Ophthalmic Mutual Insurance Company, they found an interesting findings. They found that medication errors were 2% of all claims, but 4% of all defense costs and 12% of all indemnity payments. So it shows that the costs are disproportionate to the number of cases. So they're more costly than other types of things. And corticosteroids and antibiotics were the most common medications implicated in those claims. So antibiotics, steroids, pretty high risk for lawsuits, relatively speaking. In 2002, Harvard's medical institution reviewed their risk management foundation. They reviewed cases for the decade of the 90s. They reviewed 2,047 cases. 6.3 of them were related to medications. 3%, or a total of 4 cases, were related to steroids. And what they found, they divided all the cases up into preventable versus non-preventable cases. 2 of the 4 were considered preventable. What makes it important is if you look at the indemnity payments of those 2 groups, non-preventable complications, the average indemnity payment was only about $30,000. Preventable, meaning you could have avoided this if you hadn't done something wrong, the indemnity payment went up to $332,000. So it's a 10-fold increase in those 2 groups. Common plaintiff allegations, if you look through this and see what they complain of: lack of informed consent, incomplete or unclear consent, negligent use, incorrect dose, communication failure between the physician and the patient, failure to monitor for side effects or for adverse effects, the most appropriate drug not used, and inappropriate length of treatment or route of administration. So basically, the interesting thing is that steroids were the medication most frequently involved in lawsuits alleging lack of informed consent. So those are the ones that the providers didn't go through the side effects and talk to them about the risks and those sorts of things the most often, or at least that was the allegation. For those of you who are familiar with a Westlaw database, we did a Westlaw review of steroid-related lawsuits. And the Westlaw is kind of like Ovid or Medline for lawsuits. Right, so the difference is that the lawyers put the information in themselves. So it's not completely representative of every single case that goes on, and not every single case has the same amount of detail. So you get bits and pieces and fragments of these different cases. But we reviewed it over a 12-year period, and we looked for malpractice and steroid use or corticosteroid use. And so we reviewed all these cases, and we excluded them if it turns out that it wasn't negligence, or if the case had to do with not giving steroids for like premature babies and things like that for lung development. So those were all excluded. And so you can see how we broke that down, kind of like you would a Prisma diagram. We started off with 414 citations. 202 were excluded because it wasn't a malpractice suit. 99 were excluded because they weren't relevant. And then 30 were excluded because they just didn't have enough detail to really make any sense of it. So we reviewed 83 cases. And what we found was the specialty was known in about half of the cases. Dermatologists were the most commonly named. Otolaryngologists were about 4% of them. And we know the complication in a lot of them. Now, if you look at these numbers, it doesn't add up to 100% because more than one complication could be have occurred with each patient. But avascular necrosis was one of the highest. Then you get mood changes, infections, bony complications, dermatologic complications, so on and so forth. Major stroke, suicide. There were some early deaths. People had profound depression and killed themselves from the steroid use, so that's a real thing. And then if you look at the allegation, and this is what they are alleging the problem was, or the malpractice was, negligent use of the steroids or informed consent issues was, the vast majority of the problem, right, or of the alleged problem. So the verdicts, if you look at this, almost 60% were for the defendant, for the physician, 30% were for the plaintiff, 12% of them settled. And if you look at the payments, the monetary awards, it ranged quite a bit, from $25,000 to $8.1 million, with an average of award over $1 million. So it's a big deal. So, really the take-home message for this, in my opinion, is the negligent use and the lack of informed consent, or the informed consent issues. Those are the two big things. And if you look at this, couple things to keep in mind. There are limitations with these things. First of all, you don't have the total number of lawsuits. You don't have the total number of patients that have been treated with the steroids. So you can't really calculate a true incidence or a true risk. So we don't know if this is 1 in 100 million or 1 in 100 of patients that or providers that are getting sued. They're not comprehensive scenarios. Like I said, it's the lawyer that are putting those things in. It's almost like the old Wikipedia when people would add things whatever they wanted and it was open. So you can't necessarily get a comprehensive scenario. And they also don't address the appropriateness of the claims. So was this a frivolous lawsuit, or did this lawsuit have some merit? It's not addressed in a lot of these papers. But the thing to keep in mind, and this is, I think, again, really a take-home point, most of these cases that we reviewed, they indicated that negligent use of steroids occurred just because a complication or a bad outcome occurred. And so if you think about that from a medical or a legal standpoint, really negligence most closely approximates an informed consent issue. Right? So if you inform them that, yes, you can get avascular necrosis, it's not negligence because that happened, but because that happened, people alleged negligence on the part of the provider because there wasn't the appropriate informed consent. So what constitutes informed consent? Well, that varies depending on where you live. And if you practice in Washington, I would encourage you to look at the Washington state statutes. I can tell you in Wisconsin, it is my duty to inform patients about viable alternatives to treatments and the risks and benefits. However, I have no duty to disclose beyond what a reasonable, well-qualified physician would know. Now, this is important. This used to read, I have to provide them what a reasonable patient would want to know. That's what they used to read. And so, fortunately, our lawmakers had some sense and they changed that. So I have to tell them what any other well-qualified physician would tell them. I don't have to tell them detailed technical information that they wouldn't understand, risks that are apparent or known to the patient. So again, if they have been on prednisone 100 times and they've already had avascular necrosis, well, I don't really have to tell them about that. Or extremely remote possibilities that might falsely or detrimentally alarm the patient. All right, so again, we don't really know what avascular necrosis rate is. So is that enough to warn them? I would argue, yeah, probably, because it can be pretty life-altering depending on the individual and their life activities. In the United Kingdom, the patient's case notes and/or consent form has to be used to detail the key elements of the discussion with the patient. In Canada, a patient must be sufficiently informed of all material risks associated with any form of treatment in order to make an informed decision. However, they say a risk that's a mere possibility isn't necessarily a material risk unless the consequences, even though rare, are serious. So something like blindness during sinus surgery, yeah, that's pretty rare, but it's a pretty big one. So I would consider that a material risk. The key components of the informed consent decision. Now, I'm not an attorney. I've never practiced any kind of law or studied any kind of law, but this is what the articles say, and I think a lot of it's common sense, but good to say it either way. So you have to have a rationale for the use of the steroids, right? You have to explain that rationale and what your thoughts are on it. The expectations of the steroids. Why do you expect them to benefit from the steroids? You see a nose full of polyps, you know steroids shrink those polyps, they will feel better. That's the rationale, that's the expected benefit. Alternatives to steroids. Just like everything else, you've got to list the risks, benefits, and alternatives of that. What else can you do for them? You could cut them out. You could give them a topical wash, those types of things. The material risks associated with those steroids, those things that we talked about. The right to refuse therapy is always important to include. And then you have to tailor that discussion to the individual. Right? So if, like I said, if someone has been on prednisone 100 times, you probably don't really have to have that much of a conversation with them. However, if this is the first time and they are a high caliber athlete and you're going to give them prednisone, and that prednisone may put them at risk for avascular necrosis, and they won't be able to finish their athletic scholarship or something like that, well, that's probably something you should talk to them about. If they don't have the intellectual ability to discuss that, you have to put it in terms, just like we do with surgery, so that they can understand. It's important to document this. Document that it occurred. Document that you had this, why you're using the steroids. If you're using a longer course than you normally do, why are you using it a longer course? Are their polyps so bad that it's hanging out of the nose, so you're going to use 21 days instead of 14 days? Explain that. If the patient has a response, if you know that they respond well to prednisone, then include that. Right? And then objective findings. If their nose is so packed full of polyps that you can't get a scope in there, document that. Document that you've seen that. And then consider using a patient-reported outcome measure. Document that with the quality of life, how they're being impacted. When you bring them back, how are they feeling? And again, justify that their use. People ask me about a written consent. Do you get a written consent? I do not get a written consent for this. What I have been told is that a malpractice attorney that's worth a darn can get a written consent thrown out. That's why it's important to document it in your electronic medical record. So they'll never get the medical records thrown out of court, and so it's important to get that. It's also not practical, So the residents give me a hard time about how many calls the rhinologists get as opposed to everybody else, and the sinus patients call a lot. If they're calling and they want prednisone, you can't get them to drive in and fill that out if they live an hour away. So it's just not practical in all scenarios. It also does not replace the discussion. You have to have that informed consent discussion regardless of whether they're signing a piece of paper or not. But it is important to document that you had the discussion and that they had provided an informed consent. So this is my dot phrase. We use Epic in Milwaukee, and so with 4 keystrokes, I can get this to populate. And although this looks like a lot, I can get through this. Now, again, it's like anything else. We've been through these conversations a million times, so I can rattle this off to my patients in probably about a minute and a half, pretty much any patient, anytime. Now, if they have questions, that changes things. But this is what I will do. And then the last line says, informed consent was obtained for the use of prednisone if I talk to them and I go through this with them, even if they don't agree to prednisone, I leave that in there, just delete the last sentence. So it is in the medical record that we had this discussion. And they call 2 days later and they want oral prednisone, it's in there and that we've had that discussion. Right? So again, that is documenting that conversation occurred. Tips regarding the steroid use, again, use data to support that. And that's a bit of a loaded comment because we don't have a whole lot of data with that. But it's important to use data if you have that. Use the lowest possible dose and the shortest duration. Follow the community standard of care. Now, you may very well be the community standard of care, and that's okay. But if there are other people who are doing different things, then it's good to know what your partners are doing and those types of things. Consider topical therapy if you can. Discuss the risks and document that, like we said. Communicate with the patients and the providers. The other nice thing about putting this in your notes is that your notes get sent to the primary care doctors. And so they have that and they can look through that. And that can potentially tip them off on things to look at. You want to consider getting them in to see people. If they have glaucoma, get them in to see an ophthalmologist, or tell them, make sure you're seeing your ophthalmologist on a regular basis. The good documentation is important. Contraindications, be aware of that. We have a What is Oral Prednisone handout, and if anybody's interested, I'd be more than happy to email that to you. It's part of our after-visit summary. I can put it in their EPIC, in their after-visit summary, and they get that. And then I document that they were given our What is Oral Prednisone handout. So not only did they get it, but the last line of that What is Oral Prednisone handout says, if you have questions or concerns about using prednisone after reading this, call me. And then I document in the chart that they have that. Again, like I said, consider referring them to a specialist. So I have 8 seconds. We tried to go through these steroids. They are costly. They're disproportionate costly. They work great, but there are risks associated with those. Open dialogue is important, and that's it. All right? Any questions while Greg's coming up here? And again, I'm going to be around all the rest of the day, so if you have questions. Yes?
I'm using a lot more topical steroids, and is there a regulation that produces just not irrigation and stuff like that?
So the short answer is, what's that? Yeah, so the question is where people in general are using a lot more topical steroids, and so are there informed consent issues for the topical budesonide? And so no is the short answer. And again, this is in my humble opinion, and it has to do with the dose. We know all the side effects occur from dose and duration. The higher the dose, the longer the duration, the more likely they are to have those problems. The dose with budesonide is so low that it's really not clinically significant. Yeah?
Great talk. I think the Academy has emphasized this point probably the last 10 years, that one of the leading causes that ENTs get sued is just like you made it.
Yeah.
It's a great talk.
Good, thank you, I appreciate that. All right, moving on.
Thank you very much, Dave.